When it comes to chronic low back pain, much like any type of chronic pain, people are very interested in being able to equate that pain to something that they can see objectively on some sort of diagnostic image, right? So something pathoanatomically. And in the context of chronic low back pain, people might often expect to see a herniated disc or some subluxation in the vertebra that would explain your pain, right? The unfortunate reality, I guess, a lot of times is that the majority of chronic low back pain is considered to be nonspecific. And that's just sort of a catch-all phrase, meaning like there actually isn't anything that can kind of completely hang your hat on for describing why a person has that chronic low back pain. So what I mean is that I might look at an image of somebody's back, and for all intents and purposes, it looks clean, right? Discs look healthy, no impingements on nerves, nothing like that. But yet the person's saying, you know, I have this like high impact pain that severely limits my ability to do things in life, right? Conversely, if we were to all get MRIs and we kind of gave everybody an MRI or some type of scan here at PAINWeek, chances are good we'd find some people that have like large sort of structural damage or problems in their back, but yet they're asymptomatic. So even that being said, it's not terribly clear to what extent you find something going on in the back that it equates one-to-one to the actual presentation of a person's pain and symptoms therein. So that association of pathoanatomy or pathological physiological processes in the back and pain, at least right now, is tenuous at best. That idea of needing to be able to find something objectively that tracks a person's subjective experience, right? It can really undermine the patient-provider relationship, again, as I said, because a lot of that chronic low back pain doesn't necessarily have an identifiable pathology, right? But what some of the research suggests is that observers, so whether that's healthcare providers particularly, but even like family members and friends, when there isn't some sort of clearly identified reason, right, for that pain, they tend to sort of give it short shrift. And they tend to sort of act a little bit more in a discrediting manner to folks, you know, in thinking that perhaps they're really having some sort of, you know, ulterior motive for their pain. And if I'm a healthcare provider and I'm coming to you as my patient and I'm thinking, you know, I can't really see any reason for your pain, right? What I just kind of told you is somehow like your pain is your problem, and because I can't see any reason for it, I don't even know if there's, you know, any good point in going on. At which case then that just totally undermined our patient-provider relationship. And the fact of the matter is, as individuals, we're extremely sensitive to how we perceive other people perceiving us, right? So even though I might hear you saying you want to help me, but I caught the faint glimpse of an eye roll or sort of a deep exhalation, automatically I'm thinking, this guy doesn't understand what I'm saying. He's not feeling me, like I'm not being believed. And all of a sudden that puts my pain somewhere else in terms of being appreciated or lack thereof, right? And I feel stigmatized for it, like somehow I'm the problem or I'm crazy and the pain's all in my head, and because of that, it can't be real pain. Well, what can happen sometimes is that people will experience stigma sort of perpetrated against them by a provider, right? Then they'll come to anticipate it from others. And what may happen is that if they ultimately sort of internalize it and begin to think like, maybe I am less of a person because of my chronic pain, or maybe I am going crazy, right? Then all of a sudden you start to see really negative mental health outcomes, things related to depression, and if that goes on for long enough, anxiety, and almost feeling paranoid about trying to get people to believe me, but nobody will. It's, you know, some sort of collusion against me. And if, you know, the mental health outcomes aren't really attended to, suicide happens. My recommendation for other providers would be, and let me just claim I understand that there's only so much time that any one provider has to interact with their patient, right? And everybody wants to get things done quickly and efficiently. But just take a moment, right? Allow your patient the opportunity to tell their story so they can feel that they're heard, right? And that you're actively trying to collaborate with them. Recognize that as a provider, I'm a pain expert, but I'm not an expert in an individual's lived experience, right? The only way I'm gonna come to appreciate that is by having them tell me about it and not interrupting them. There's some other research that shows it takes most healthcare providers about 20 seconds before they interrupt their patient to then put forth what they think is going on. Again, that undermines the whole kind of rapport building, the therapeutic alliance, which I argue is really the foundation for putting your patients on track for better outcomes, because it's a chronic condition. They're gonna come back and see you every 6 months, 3 months, whatever the setup is. That therapeutic alliance is gonna be the cornerstone for being able to, move positively throughout that course of treatment.